Good day, future RMTs. Welcome to our discussion about adrenal function. Our learning outcomes and learning objectives are as follows. Number one is to recall the function, biosynthesis, metabolism, and of mineralocorticoids and glucocorticoids. And of course, to interpret laboratory results to determine abnormalities in the metabolism and synthesis of mineralocorticoids and glucocorticoids. To start with, I want you to know and I want you to remember, guys, that the adrenal gland, okay, is the one responsible for the production of our steroid hormones. These steroid hormones or steroids constitutes one of the more complex groups of hormones. Although these hormones are structurally similar and produced by various steroid organs, or I'm sorry, what I'm saying is, although these compounds are structurally similar, okay, structurally similar ang ating steroid hormones because of its cholesterol as the backbone, no, uh, the biochemical effects of these steroid hormones differs from its various uh, action. Let's say, for example, the mineralocorticoids is the mineralocorticoids is for fluid and electrolyte balance. The glucocorticoids is for the glucose production and protein metabolism. Okay. Now we have here what we call the adrenal gland. No, adrenal gland is a pyramid-like shape in adult and located above the kidney, and it is composed of. I'm sorry. It is composed of two distinct, no, gland, no, the outer gland and the inner gland. That is your adrenal cortex and the adrenal medulla. Adrenal cortex is the outer region. Take note, ha, that adrenal cortex is the outer region of the adrenal secreting the steroid hormones. And take note, guys, that the adrenal cortex is the major site of the steroid hormone production. Okay. Again, remember that there are three subclasses of, or not sub, there are three classes of steroid hormones. We have your mineralocorticoids, we have your glucocorticoids, and we have your sex hormones. Generally, mineralocorticoids, okay, is for fluid and electrolyte balance. Example of which is your aldosterone. We also have your glucocorticoids, no, which is for glucose metabolism. No, I'm sorry, glucose production and protein metabolism. Example of which is your cortisol. Okay, remember that the adrenal cortex is the outer region, no, the outer region of the adrenal gland that is capable of secreting steroid hormones, and that is the major site of the steroid hormone production. Okay, remember, no, that steroid hormones are composed of a basic structure called as your cyclopento perhydropentrin. Okay, that is your cyclopento perhydropentrin, no, or also known as the CPPP ring. Okay, remember, guys, that the cyclopento perhydropentrin or the CPPP ring is a 17 carbon skeleton. No? This is a 17 carbon skeleton that is derived from our cholesterol. Remember, people of God, that cholesterol is the parent chain no, or the parent cell, no, of steroid hormones. Wherein, no, wherein uh, it is being metabolized in the in the mitochondria to become your pregnenolone. Remember also, guys, that cortisol hormones are synthesized from the LDL. As you all know, LDL is your low density lipoprotein, which is derived to the adrenal gland. No, take note ha, derived to adrenal gland where it is taken up by LDL. Now remember also that the secretion of adrenal gland of glucocorticoids and androgens is regulated by our secretory hormone, which is your ACTH. Remember guys that the ACTH is under the control of our hypothalamus and hypopituitary or hypothalamic pituitary axis, no? Through the secretion of the CRH or the CRF, no? Your corticotrophin releasing hormone or your corticotrophin releasing factor released by the hypothalamus so that the pituitary gland will secrete this ACTH. Remember again that the secretion of adrenal gland, particularly the adrenal cortex, where the site of of the steroid hormone is seen, is being regulated by our ACTH. No? The secretion of glucocorticoids, no? And even our mineralocorticoids is sometimes regulated by ACTH. But mostly, the regulation or the secretion of glucocorticoids is being uh, regulated by your ACTH. So again, this is just a preview of the secretion of our steroid hormones, particularly our glucocorticoids and mineralocorticoids. Now, like what I said, there are three classes of steroid hormones, the glucocorticoids and the mineralocorticoids. However, ano yung pangatlo? The third one is the sex hormones. Okay? Since the sex hormones is not being produced by our adrenal gland, but rather by our gonads, we're going to have a separate discussion on how our sex hormones is being produced. Now, since we have here your mineralocorticoids and glucocorticoids, take note guys that the mineralocorticoid secretion is mainly regulated by what you are almost familiar with, which is your renin angiotensinogen aldosterone system. I will not go deeper. I will not explain this anymore because I'm assuming and expecting that you already know by heart, by mind, by soul, by body what is renin angiotensin aldosterone system. Okay? So remember, yung glucocorticoids, yung glucocorticoids natin is being regulated by ACTH. Okay? Yung ating mineralocorticoids, sino po ito? Regulated or controlled by your renin angiotensin aldosterone system. Okay. Now, moving forward to our adrenal cortex. Like what I've said, adrenal cortex is the true adrenal gland wherein dito nangyayari yung production of our steroid hormones. If we are going to recall the anatomy and physiology of our adrenal cortex, it is divided into three zones. The zona glomerulosa, which is the outer layer, which accounts to 10% of our adrenal cortex. The adrenal fasciculata, which is now at the middle, no? The middle portion of our adrenal cortex, which accounts to 75% of the adrenal cortex. And lastly, we have your zona reticularis, which is 15% of our adrenal cortex. The other adrenal is the adrenal medulla, which is the inner. Now, discussing or let's focus first in zona glomerulosa, fasciculata, and reticularis. Like what I've said, zona glomerulosa is the G zone from the word glomerulosa, the G zone, which is approximately 10% of the adrenal cortex. Take note, people, that our zona glomerulosa can synthesize mineralocorticoids. Synthesize mineralocorticoids. At sino pong mineralocorticoids ito? It's no other than your aldosterone. Remember, people, if you still remember, no, for the purpose of reviewing, aldosterone is an essential hormone for the sodium retention, potassium, and acid-base balance. Okay? Tandaan po natin that our aldosterone is not only limited for the sodium retention, no, but also for potassium and acid-base balance. Primarily because of sodium retention. Diba? Oh, hindi na natin re-reviewin si Raas. Alam ko na-figure out nyo kung paano na-produce yung ating aldosterone through angiotensin 2. Okay? Now, a low cytoplasmic to nuclear ratio and small nuclei with dense chromatin with intermediate lipid inclusions is the structure of our zona glomerulosa. Again, low cytoplasmic to nuclear ratios. Moving forward to our zonar fasciculata, which is the F zone and approximately 75% of our adrenal cortex is the one that is capable of secreting or synthesizing our glucocorticoids. Having said, no, that it is responsible for the synthesis of our glucocorticoids, these glucocorticoids is no other than your cortisol and of course our cortisone. Now remember guys that glucocorticoids, cortisol and cortisone are all critical for blood glucose homeostasis and even in blood pressure. Okay? And lastly, we have your uh, by the way, before I forget, we also have what we call the fasciculata cells. What is this? What is with fasciculata cells? Okay? When we said fasciculata cells, these are cords of clear cells with a high cytoplasmic to nuclear ratio, and as opposite to our glomerulosa cells, no? And it is the one that is capable of generating the androgen precursor, no? Take note that your zona fasciculata, particularly the fasciculata cells, is the one that is capable of generating androgen precursors, which is important in the sex hormone. At ano naman po itong androgen precursor na ito? This is our DEA. DEA stands for dehydroepiandrosterone. Dehydroepiandrosterone. Okay? Which is a sulfated in the innermost layer of our fasciculata. And lastly, we have your zona reticularis, which is the R zone, and approximately 15% of our adrenal cortex. This is a sharply demarcated with lipid deficit cord of irregular dense with lipofuscin deposits. That's why if you will look on our illustration, no, medyo mas darker ang color ng ating zona reticularis. And lastly, in our adrenal medulla, We have your chromaffin cells. If you still remember, the chromaffin cells are important cells doon po sa ating urinary metabolite na H5, 5-HIAA, 5-hydroxyindole acetoacetic acid. Okay? Moving forward, this is how our hormones is being produced. Now, like what I've said, the Zonar Fasciculata, no, is the one responsible for the secretion of our glucocorticoids. Okay? Fasciculata, glucocorticoids, glomerulosa, mineralocorticoids. Medyo magkaiba lang, no? Pero akala mo, pag G, gluco, no. It's F, no? The fasciculata is for the glucocorticoids, your cortisol and your corticosterone, no? And your zona glomerulosa is your aldosterone. Zona reticularis is your androstenone. Androstenedione. Now remember guys, no, ito naman yung focus ng mga pharmacy. Ang focus ng pharmacy, yung mga enzyme deficit. Okay. If you are going to take a look with this, yung conversion ng ating cortisol in the zona fasciculata, zona reticularis, and zona glomerulosa are all just the same. They are being metabolized or synthesized by the help of enzyme P450 now to convert it into pregnenolone. However, now the different enzymes will convert the pregnenolone in different zones of our adrenal cortex. Let's say, for example, the cortisol, no? The cytochrome P450 C17 is the one that will convert our pregnenolone to 17-hydroxy pregnenolone. And the 3 beta, okay, the 3 beta dihydroxy 4,5 isomerases is the one that will convert it into what we call uh, 11 dihydroxy 11 deoxycortisol, okay, to convert it into your cortisol. Okay? So ito po yung sinasabi natin kanina na DEA. Okay? Your dihydroepiandrosterone. Now, cortisol is the principal glucocorticoids. Take note, cortisol is the principal glucocorticoids and that is usually referred as our stress hormone, no? The primary stress hormone. The synthesis of cortisol is being regulated by the hypothalamic pituitary axis through the release of our ACTH. Remember guys that our cortisol is mostly bound into glycoprotein transcortin. Okay? Again, our cortisol is mostly bound into our principal into our tawag dito, glycoprotein which is your transcortin. Remember, like what we said, cortisol stimulates gluconeogenesis in our liver. Now, since it stimulates gluconeogenesis, ano yung nangyayari? It will, nasa nating pasulat? Yan. It will increase our glucose level. Having said that there will be an increase in glucose level, there is what we call the hyperglycemia. And take note, guys, that our cortisol has what we call anti-insulin effect. Ay bakit anti-insulin effect? Bakit nga po? Anti-insulin. Again, if you still remember the action of our insulin hormone, insulin is to decrease or allow, no? Para mas maganda, allow the entry of our glucose to the cells para ma-metabolize, magamit. And ito namang si cortisol, hindi na yun ina-allow. Pinatataas pa nga na yung glucose effect. No? So, ibig sabihin, si cortisol has an antagonistic effect with our insulin.
or should I say the other way around? Tama pala. Cortisol has an antagonistic effect to our insulin. Okay? Now, take note that in the inhibition of the secretion of ACTH, there will be a problem in our cortisol. Kapag po wala tayong ACTH production, there will always be a problem in the production of our cortisol. Okay? Remember also that our cortisol can serve can serve as an anti-inflammatory and immunosuppressive actions. It has an anti-inflammatory and immunosuppressive. In what way? Paano po 'yun? No? Remember guys that the value remember guys no that this cortisol no as a therapeutic agent for our rheumatoid arthritis, systemic lupus erythematosus, and myasthenia gravis. No, multiple sclerosis pala. Ano myasthenia gravis? Multiple sclerosis. Okay, repeat. Si cortisol po natin has an anti-inflammatory and immunosuppressive actions. Okay? Bigay siyang gamot doon sa may mga immunologic or autoimmune disorders such as rheumatoid arthritis, isulat po natin, systemic lupus, erythematosus, nako, matosus, yan, and multiple sclerosis. Multiple sclerosis, alam niyo naman yung multiple sclerosis. Okay? Remember also that the major action of our cortisol or the major role. Burahin natin yung ibang nakasulat para hindi masyadong nakakalito sa inyong mga mata. Yan. Remember guys that the major action or the major role of cortisol, okay, is the enhancement of glucose production from proteins and amino acids. Kagaya ng sinabi natin kanina, that it stimulates gluconeogenesis is its major role. Okay? Remember also guys that the cortisol circulates primarily bound to plasma proteins. Okay? That is your transcortin. Or meron din po tayong tinatawag na cortisol binding protein or cortisol binding globulin. Okay? Now, maliwanag po tayo na a major role ni cortisol ay ano? I-promote ang glucose production from proteins and other amino acids. And aside from that, no? Aside from that, to enhance the protein metabolism or protein breakdown. Okay? Now, therefore, take note, people of God, take note, okay? Bakit nagkaroon ng anti-inflammatory effect ang ating cortisol? Because of its protein synthesis. Because of its effect on protein synthesis. Now, if you are going to measure cortisol, it will be nice and if appropriate if you are going to measure the level of cortisol on its peak level, no? May peak level po ito. Kaya nga ano yung sabi natin sa cortisol, siya ay merong diurnal variation. Ang peak level niya is between 8 to 9, sometimes 6 to 8, no? According to yung ACTH, kung titingnan natin. So 8 to 9 a.m. is the peak, and 10 to 12 a.m., 10 p.m. to 12 a.m. is the lowest point. Now, cortisol can be measured in serum, it can be measured in plasma, and it can be measured in saliva as well as in urine. Kaya nga meron tayong tinatawag na urine-free cortisol levels. All right. Having said that we have your urine-free cortisol levels, it is nice to know that these urine-free cortisol levels are sensitive enough, no? Are sensitive indicators of what we call adrenal hyperfunction. Aba sir, ano naman po yung adrenal hyperfunction na yan? Ibig sabihin, excessive, no? Exogenous cortisolism. Alright. So meron tayong mga tinatawag na urinary metabolites of cortisol. Number one, we have your 17-hydroxycorticosteroid. No? Again, remember guys that we have what we call your 17-hydroxycorticosteroid. Remember that this can be measured through what we call Porter-Silver method, which will give us a yellow color of the analysis. The reagent used in your Porter-Silver method or your Porter-Silver assay is the use of 2,4-dinitrophenylhydrazine in your sulfuric acid and alcohol. Take note guys that the Porter-Silver assay for urine cortisol and derivatives capitalizes in the reaction long employed for carbohydrate analysis. Okay? Now, remember that we have here what we call the dihydroxyacetone, no? The dihydroxyacetone or the dihydroxy 20 ketone. Okay, ano po yung meron dito? Okay. This is a steroid reaction with your 2,4-dinitrophenylhydrazine, which is your reagent used. Okay, ano yung mangyayari dito? It will react, no? It will react with our 2,4-dinitrophenylhydrazine, no? Itong ating 1721 dihydroxy 20 ketone or ON or sometimes referred as the dihydroxyacetone, no? The dihydroxyacetone will react with our 2,4-dinitrophenylhydrazine to form a yellow derivative. Okay. Ano naman po itong mangyayari dito? This yellow derivative, no? Take note people that this yellow derivative is measured at a maximum wavelength of 410 nanometers. Again, this yellow derivative is measured at 410 nanometers. Now, no? Now, there is an initial step that includes an enzymatic hydrolysis. Okay? Wherein the steroids are extremely susceptible to damage if acid is used. Ay teka lang sir, eh bakit mayroong sulfuric acid diyan? Kaya nga nineutralize natin siya with the use of our alcohol. That's why we use alcohol as our organic solvent. Okay? We use alcohol as our organic solvent. Now remember people that this 17-hydroxycorticosteroid, no, there is what we call liver degradates all glucocorticoids to metabolites excreted urine. So si liver ang nagde-degradates natin dito, nagde-degrade dito so that it will be excreted through our urine. If you still remember yung isang function ng ating liver, no, convert toxic materials into a non-toxic material so that it will be excreted by our kidney. Now, on the other hand, we have your 17 ketogenic steroids. Ito naman, no, si ketogenic steroids naman is being measured by the Zeeman's reaction, which will give us naman a reddish purple color, and the reagent used is meta-dinitrobenzen. Kanina, yung ating reagent sa Porter Silver ay si 2,4-dinitrophenylhydrazine. This time, in our 17 ketogenic steroid, our, no, our uh, reagent is your meta-dinitrobenzene. Okay, so ano naman yung mangyayari dito sa ating Zimmermann's reaction? Now remember, any steroid with an oxygen-containing carbon, no, and a group of carbon, such as your carbonyl or hydroxyl, no, undergoes reaction from a 17 ketogenic steroid. Now remember that once that these uh, compounds containing either the carbonyl group or the hydroxyl group reacts with our meta-dinitrobenzene, it will give us a reddish purple color. Okay? So that is with our cortisol. Now remember, no? In cortisol disorders, we have what we called hypercortisolism and we have your hypocortisolism. Ano naman po yung pinagkaiba? Siyempre, pag sinabi nating hyper, increase, excuse me, increase in the level of our cortisol. At kapag sinabi nating hypo, edi mababa. Now, having said, no, pag-usapan muna natin what is hypercortisolism. When we said hypercortisolism, this is a condition that is characterized by excessive production of our ACTH. Having said that there is a excessive production of our ACTH, what will happen? It will cause an increase in the production of our cortisol. Ibig sabihin, meron siyang positive feedback. As the product increases, the stimulating hormone or the tropic hormone is continuously in producing our tropic hormone. Hypercortisolism is also known as your Cushing's syndrome. Now, what is the difference between Cushing's syndrome and Cushing's disease? They are different, huh? Cushing's syndrome and Cushing's disease are different. In what way? Number one, take note that Cushing's syndrome is increase in cortisol and ACTH production as a result of tumor. Because this tumor mimics the action of the cell. Kung nagsisekret ng ACTH, edi nagsisekret din siya. Okay? While Cushing's disease is an increase in cortisol caused by excessive development and activity of pituitary gland. Okay? Take note that the Cushing's syndrome, no, the Cushing's syndrome was first described in the year 1930, no, in the year 1930 by Henry Cushing's. Okay? By Henry Cushing's. Now, these are the signs and symptoms of a patient with Cushing's syndrome. Weight gain with thin extremities, hyperglycemia. Bakit hyperglycemia? Yung pasyente na mayroong hypercortisolism. Si cortisol, pinopromote ang glucose production. Okay? There is also thinning of the skin, which can lead into poor wound healing, hypertension, hypercholesterolemia, and decreased WBC. Okay? Ngayon, yung pong ating Cushing's disease, kagaya ng sinabi natin, development and activity of pituitary gland. This is what we called hyperplasia. Pit, uh, Adrenal hyperplasia. Okay? Or other thing is pituitary hyperplasia. Kapag meron kang pituitary hyperplasia, there is an increased production of our ACTH, causing elevations of plasma cortisol, causing elevations of our cortisol. Kapag naman tumor, it develops, no? Pag naman tumor, kagaya ng kay Cushing syndrome, it mimics the cell. Having said that it mimics the cell, it stimulates the production of ACTH by pituitary gland. Therefore, it increases also the production of our cortisol. Okay? So yun lang. Naalala ko lang idagdag. Now, what are the tests for hypercortisolism? The screening test definitely for our hypercortisolism is our 24-hour urinary free cortisol test. Okay? Or you can use the overnight dexamethasone suppression test. And remember that, guys, that the dexamethasone or dexamethasone suppression test is most widely used salivary cortisol test. And the confirmatory test includes low dose dexamethasone suppression test, okay, and the midnight plasma cortisol, and of course the CRH stimulation. Okay, so we have here that will help us to differentiate the suppression control of our cortisol. So, kapag po pituitary tumor or hyperplasia, again, kapag hyperplasia, ito ay hyperplasia. Hyperplasia, ito ay Cushing's disease, excessive growth, excessive development. Kapag tumor, ito ay Cushing's syndrome. Okay? So kapag naman daw binigyan natin ng dexamethasone, 50% suppression ang mangyayari. Kapag ang binigay natin ay metrapone, increased 17 OHCS. Ectopic ACTH production, no suppression sa dexamethasone and variable response sa metriprapone. Okay? Adrenal tumors, no suppression and no response sa ating other drug. Now, what is the laboratory values in Cushing's syndrome? Okay. Uh, Pituitary tumor or hyperplasia, cortisol high or normal, ACTH high, and the urinary 17OH is high. Ectopic ACTH is high, plasma ACTH is high, and urinary 17OCH, OHCS is high. Kapag adrenal tumor, mababa po yung ating ACTH plasma. The rest is high. Now, there is a procedure for our overnight dexamethasone suppression test. So, anong mangyayari? A patient will be given 1 milligrams of dexamethasone orally given between 11 p.m. to 12 a.m. A blood collection will be done, no, between 8 a.m. and 9 a.m. Ito yung peak eh. Aside from that, there will be also a measurement of urinary cortisol, the 17-OHCS. Now, if the cortisol value is less than 5 UG per DL, it, excuse me, If the cortisol level is less than 5 UG per DL, o ba ay may sound? Hello. Yan. If the cortisol level is less than 5 micrograms per DL and our 17 urinary uh, hydrocortisone is less than 4 mg per grams of creatinine, that's the unit, it deemed to be, it seems to be normal. No? Ayan. Normal kapag ganun ang result natin. Okay? Now, if the result is greater than 5 UG per DL and greater than 4 mg per UL, mg per grams, then it means it is abnormal. Moving forward to hypercortisolism, hypocortisolism is mainly caused by adrenal damage. Okay? Yung hypocortisolism, meron dalawang kondisyon. Primary hypocortisolism and secondary hypocortisolism. Definitely, most of the cases, adrenal damage, primary. If there is a involvement of hypothalamus and pituitary gland, that is your secondary hypocortisolism. Now, let's discuss what is primary adrenal insufficiency. Primary adrenal insufficiency is characterized by this decreased production of our cortisol, wherein 90% of our adrenal cortex is being destroyed. Having said that there is a deficiency in our cortisol, there is also deficiency in our aldosterone. Bakit? Ibig sabihin, pati po yung ating zona glomerulosa is being affected. Merong damage since that is the outer layer of the adrenal cortex. Now, ACTH is excessive. Bakit? Bakit excessive yung ACTH natin? Kasi hindi naman nagre-react, no, ang ating ACTH sa ating adrenal gland. Now, primary adrenal insufficiency is correlated into what we call Addison's disease. Addison's disease is a endocrine problem wherein there is a decreased production of what we call cortisol. Okay. Addison's disease is a defect in the synthesis of hormones by adrenal gland. Bakit? There is a damage. ACTH level is quite elevated, no? And electrolyte imbalance. This adrenal damage can lead into electrolyte imbalance and ACTH elevated. Bakit po ang ating ACTH ay elevated? Kasi nga, walang nagre-react sa ACTH. Hindi naman napupuntahan ng ating ACTH ang kanyang target cell. Pero walang receptor, walang action. Kaya siya mataas. Now, bakit there is an electrolyte imbalance? If you are going to remember this one, there is an aldosterone deficiency. Aldosterone deficiency can lead into the problem in the retention and reabsorption of our sodium. Thus, it will also affect the retention and the homeostasis of our potassium. Having said that the potassium and sodium is affected by the regulation of our cortisol due to the problem in the adrenal damage, it can lead into what we call electrolyte imbalance. At dahil may electrolyte imbalance ka, pwedeng maapektuhan din yung acid-base balance mo. Now, what is the screening test for primary hypocortisolism? The screening test for primary hypocortisolism is no other than the ACTH stimulation test. Bakit? Bigyan mo ng ACTH yan. Kapag ang ACTH ng pasyente mo mataas pa din, ibig sabihin problema talaga niya ay yung kanyang adrenal gland. Diba? Nag-induce ka ng synthetic ACTH, wala pa ring reaction. Ibig sabihin, it is not your pituitary gland ang problema. The problem relies on your cortisol. The problem relies on your adrenal. Mataas ang ACTH, mababa ang cortisol, mababa ang aldosterone. Problema natin dito is your adrenal gland. Hindi nag-react sa ACTH eh. Bakit si aldosterone mababa din? Hindi naman siya regulated by ACTH. Destroyed nga din ang iyong medulla, yung yung adrenal medulla, correct? Adrenal cortex, sorry. Adrenal cortex, particularly your fasciculata and glomerulosa. Si glomerulosa nga, yung aldosterone outer layer, the G zone, affected. So, ibig sabihin, kahit si angiotensin 2 mag-react, walang production. Kasi nga, sira, mayroon damage. Yung receptors is being affected. How about for secondary cortisolism? ACTH production is low due to the damage of hypothalamus and pituitary. O ngayon, gamitin natin dito si ACTH stimulation test. Kapag si ACTH, binigyan natin at nagkameron ng production ng cortisol, hindi si adrenal ang problema mo. Ang problema mo, si pituitary o kaya si hypothalamus. Baka nagkameron ka na ng hypopituitarism. Kaya nagkameron ng problema sa iyong adrenal gland. It's production ng cortisol mo. Okay? The ACTH stimulation test is also known as the Corticotrophin stimulation test. Ito, it differentiates the secondary adrenal insufficiency from tertiary adrenal insufficiency. Bakit? Kapag secondary, decrease or no ACTH. Kapag tertiary, adrenal insufficiency, increase in ACTH, no response. Ano ba yung corticotrophin na yan? This is a synthetic cortisol or aldosterone stimulator, which is given intravenous or intramuscular, and the amount is 250 micrograms. Okay, so that is for cortisol. Now, how about for mineralocorticoid aldosterone? That is the most potent mineralocorticoid. Bakit? It regulates water and electrolytes, not only sodium but also potassium and chloride. And since it regulates sodium, potassium, si sodium ay merong role in the maintenance of blood pressure, nire-regulate din ang aldosterone natin ang blood pressure. Kaya nga yung RAAS, paulit-ulit na yan. Last sem pa. Ay bakit pag may problema tayo sa aldosterone, meron din tayong electrolyte imbalance. Bakit? Because aldosterone promotes 1:1 exchange of sodium and potassium or your hydrogen. Kaya nga importante rin ito sa acid-base balance natin. Di ba? Pag ikaw yung nag-vomit, suka ka ng suka, napopromote yung exit of your hydrogen, kaya nagiging acidic. Ayan, RAS ulit. RAAS ulit. Okay? Now, we have what we call the 18-hydrosteroid dehydrogenase, which is an enzyme needed for the synthesis of our aldosterone. Saan ga nagsisynthesis ang aldosterone? Sa zona glomerulosa, the G zone, 15%. Okay. Kung may problema tayo sa cortisol, dapat may problema din tayo sa cortisol, sa aldosterone natin. Hindi pwedeng wala. Na meron tayong primary aldosteronism and secondary aldosteronism. Ano po yan? Kapag sinabi nating primary aldosteronism, it is caused by aldosterone secreting adenoma. No? Merong increase in our aldosterone and low plasma renin. Now, take note of this. Remember, the distal delivery of the sodium is increased because increased sodium chloride reabsorption in the cortical collecting duct by action of aldosterone inhibits salt reabsorption in the proximal convoluted tubule as a result of volume expansion. No? Ulitin po natin. The distal delivery of the sodium is increased because increased sodium chloride reabsorption in the cortical, the collecting duct by the action of aldosterone inhibits salt reabsorption and the PCT as the result of volume expansion. What are the symptoms? Hypertension, hypokalemia, mild hypernatremia, and metabolic alkalosis. Bakit metabolic alkalosis? Sir, ano yung nangyayari dito? Mataas ang sodium natin. Mataas ang cations natin. Kapag minus mo sa kanya ang anions, mataas pa din siya. Kaya alkalosis. Pag, pag kinuha mo yung ating level, mababa doon sa ating normal range. Kaya alkalosis. Now, what are the tests for primary aldosteronism? The screening test is the PACPRA. Anong PACPRA, sir? PACPRA stands for plasma aldosterone concentration over renin plasma renin activity. If the result is greater than 50 PAC over PRA ratio, means it's a positive result for primary aldosteronism. No? Now, what is the confirmatory test? The saline suppression test. Infusing 2 liters of 0.9% saline for 4 hours or administering 10 to 12 milligrams sodium chloride tablets for 3 days. If the result is greater than 5 nanograms per deciliter aldosterone, then there is a primary aldosteronism. Moving forward to secondary hyperaldosteronism, it occurs as a result in excessive production of renin. Naging OA naman yung RAAS mo. Okay? There is also what we call the renal artery stenosis, which is a narrowing of the arterial renins. Arterial arteries in the renals. No? Secondary hyperaldosteronism can that result in hypokalemia includes renal artery stenosis. This is what I'm telling, no? The narrowing of the renal arteries. Diuretic therapy, malignant hypertension, Barter's syndrome, and Geetalmans Syndrome. First, ano po yung Liddle syndrome? Liddle syndrome is synonymous with what we call the pseudohyper aldosteronism. This is a congenital disorder characterized by ENaC. ENaC stands for epithelial sodium channel. It resembles primary aldosteronism clinically, but aldosterone is decreased and there is an absence of hypertension. Barter's syndrome, on the other hand, is a rare potassium-losing autosomal disorder which is caused by defect in our sodium chloride. This is characterized by increased concentration of our aldosterone and renin. Lastly, we have your Geetalmans syndrome, which is associated with defect in sodium chloride reabsorption that occurs in the distal convoluted tubule and seen, no, with increased aldosterone. Hypoaldosteronism is a condition wherein there is a destruction of the adrenal glands and deficiency of glucocorticoid. Okay? Now, this is associated with the deficiency of enzyme 21 hydroxylase, which is an enzyme responsible for the production of our mineralocorticoid. On the other hand, hyperkalemia and metabolic acidosis is seen in a patient with hypoaldosteronism. Test available is the furosemide stimulation test or upright position. A positive result includes low aldosterone level. And lastly, we have your saline suppression test, which gives you a high aldosterone level. Now we have your weak androgens, which is naman the precursor for the production of a more potent androgens and estrogen in the tissue. Now, the precursors of weak androgens includes your pregnenolone and your 17-hydroxypregnenolone. Remember that the DHEA is the principal adrenal and androgen. So pag-usapan natin yan pagdating natin ng sex hormones. Adrenal medulla is composed of the chromaffin cells that secretes our catecholamine. No? Remember guys that L-tyrosine is the precursor of catecholamines. So parang si tyrosine din yung ating precursor nino, thyroid hormone. Ibig sabihin, ito pong ating catecholamines ay amino acid derived hormones. Ala, ang galing. Yes. No? Sana na-realize na rin. These are what we call amino acid derived hormones. So ibig sabihin, yung adrenal medulla, hindi po siya steroid hormones. The adrenal medulla ay amino acid hormones. Bakit? Kasi nga, ang precursor nila is yung tyrosine. Tyrosine. Now, adrenal medulla is responsible for the production of what we call norepinephrine and epinephrine. Okay, so this is the synthesis of our catecholamines. Now, remember guys that all catecholamines are formed by the conversion of the synthesis or conversion of our tyrosine. Having said that it is derived from tyrosine, ito ay isang amino acid hormone. Okay? This amino acid contains a benzene ring. Now remember guys that the tyrosine itself derives from phenylalanine. O di ba if you still remember our amino acids, tama, wag mo nang kaisipin, no? It is derived from phenylalanine which undergoes hydroxylation reaction. Now, remember people that the name catecholamines, ano nga meron dyan? The name catecholamines are derived from the common name catechol, no? From the common name catechol. When we said catechol, it is a derivative or it is a compound that contains your, what you call this? Hydroxyl in the benzene. Okay? Hydroxyl in the benzene. This is our benzene ring, OH, OH. This is your catechol. Sana natatandaan nyo pa siya sa Chem 1. No? Siya yung catechol. 1,2-dihydroxybenzene. 1,2-dihydroxybenzene. Or ano yung other name for catechol? Aside from 1,2-dihydroxybenzene. Correct? The orthohydroxybenzene. Ba't ortho? 1,2. 1,2 ortho, 1,3 meta, 1,4 para. Uy. Okay? Now remember guys that the most common known catecholamines are your epinephrine and your norepinephrine. Remember that epinephrine, tandaan, epinephrine is adrenaline. Okay? Adrenaline. And our norepinephrine is our noradrenaline. Noradrenaline. Now, these two are important in the regulation of our blood pressure. No? May emphasis yung blood pressure. These are all important in the regulation of our blood pressure. Now, what are the sources of our catecholamines? Remember guys that the primary sources or the primary source of our catecholamines is the synthesis and storage from the chromaffin cells. Kagaya na sinabi natin kanina. okay, in the adrenal medulla. Now remember that these chromaffin cells, okay, these chromaffin cells are located at the top of the kidneys and are part of the adrenal gland. Chromaffin cells are part of the adrenal gland, no, which comprises the adrenal cortex and the adrenal medulla. Okay. Now remember, so ito na, pag-usapan natin yung synthesis ng ating catecholamines. Burahin muna natin ang nakasulat. Excuse me. Now remember that the tyrosine, no, the precursor of our catecholamines, resulting from the metabolism, no, of our phenylalanine, or the conversion of our phenylalanine enters into our chromaffin cells. Chromaffin cells. No, hindi, tama pala. Chromaffin, hindi walang ta. Okay, repeat. The tyrosine from the metabolism of phenylalanine will enter into what we call chromaffin cells. Okay. What will happen? Upon the entry in the chromaffin cells, it will undergo what we call hydroxylation. And this hydroxylation can be happen through the enzyme of tyrosine hydroxylase. Enter into chromaffin cells, undergo hydroxylation through the enzyme tyrosine hydroxylase. What will happen? It will form your 3,4-dihydroxyphenylalanine. Your 3,4-dihydroxyphenylalanine, which is known to be your DOPA. Okay? Which is which is now known to be your DOPA. Now, subsequent reactions through the enzyme DOPA decarboxylase, no, through the enzyme DOPA decarboxylase will have a removal of our carboxyl group. Okay? Removal of a carboxyl group leading into the formation of what we call dopamine. Okay? Removal of carboxyl group. Ito po yung nawala. Removal of carboxyl group. Okay? Leading into what we call your dopamine. Dopamine enters the chromaffin cells or the chromaffin vesicles that will convert it into what we call norepinephrine. Okay, na yung mangyayari, magkakameron po tayo ng tinatawag nating uh, reaction through the enzyme dopamine beta hydroxylase. Okay, ano po yung mangyayari? There will be a hydrolysis reaction. Now, this norepinephrine naman, okay, this norepinephrine will be converted into our epinephrine through the help of the enzyme phenyl phenethylamine and methyltransferase. The transfer of our methyl group. Ibig sabihin, kung meron kang deficit sa mga enzyme na ito, walang conversion ng epinephrine, walang conversion ng norepinephrine. Eh kung may problema ka na din dito sa tyrosine hydroxylase mo, that converts your tyrosine into your DOPA, di ba ga? Si DOPA, isa sa mga byproduct ng tyrosine metabolism. Natatandaan nyo ga? Oo nga. Kaya pala dapat konektado lahat. Uy, ito nangyayari 'to sa katawan natin, eh, okey? Sino ba yung norepinephrine na 'yan? Si norepinephrine is produced by the sympathetic ganglia, and the highest concentration is found in the brain and act as a neurotransmitter in both CNS and our sympathetic nervous system. The major metabolite of norepinephrine is your 3-methoxy 4-hydroxy phenyl glycol or your MHPG. Si epinephrine naman is most abundant medullary hormone. It is produced from norepinephrine and comes from the adrenal. No, this is our fight and fight hormone, flight and fight hormone, responsible for physiologic injuries, psychological threats such as stress and anxiety. Now, that any form of distress can increases cortisol level, also stimulates epinephrine. So si Epi at saka si cortisol, our primary stress hormones. Matapit na tayo matapos. Epinephrine, no, in indwelling catheter, since venipuncture may cause levels of catecholamines, so dyan tayo pwedeng mag-collect ng blood for epinephrine analysis. Now, the major metabolite of epinephrine includes your vinylmandelic acid or your VMA. Sounds familiar, right? Sounds familiar. Dopamine, on the other hand, is a catecholamine produced in the body by the carboxylation of 3,4-dihydroxyphenylalanine, your DOPA. Major metabolite, homovalenic acid. Sounds familiar? Yes. We have a condition what we call the Freochromocytoma. This is a tumor of the adrenal medulla or the sympathetic ganglia, which is most commonly seen in the third to fifth decades of life. So, ibig sabihin, doon ka sa nasa 30 to 50 years of age, which can lead into the overproduction of our catecholamines. Signs and symptoms include tachycardia, headache, tightness of chest, sweating, and hypertension. Screening test is high plasma metaphrines and your normetaphrines by high performance liquid chromatography. Okay? Clonidine test is a pharmacological test that differentiates pheochromocytoma from neurogenic hypertension. And glucagon stimulation test is a highly suggestive test for pheochromocytoma. Yan, binasa ko na lang. Yun lang naman kasi yan. And lastly, we have your neuroblastoma, which is a fatal malignant condition in children resulting to excessive production of norepinephrine. Notes to remember, no smoking or drinking coffee prior to the blood collection for catecholamines can cause falsely increased blood catecholamines. Plasma catecholamines are affected by position. Collection of blood should be done 30 minutes after the blood is in stable position. A decreased value of catecholamines when in supine position. And catheterized preferred method for blood collection to eliminate the anxiety of venipuncture. Kaya nga, undwelling catheter. And that is the end. I hope you like it. Like me and um, vlogger na pala to. Yeah, vlogger na po ako, no? Subscribe on my page and like for new videos. Good day and God bless you all.